I'm going to talk a little bit today about the work that we are doing in Ghana related to our global emergency medicine arm of what we're doing here. I've titled it Building Leadership and Research Capacity Through Clinical Training. What we've done overall is tried to build a clinical training program and embed within it the idea of clinical research leading to quality improvement and sort of readjustment of what our goals are with the training. So a little bit about the anatomy of the issues that we were facing initially. And some of these numbers I'm sure you've seen before, the fact that 90% of road traffic related injuries, deaths occur in low and middle income countries, and that the highest road traffic injury death rates are in the African region. In 2015, there was a number reported of 1.24 million, and it was ranked as the 10th leading cause of death. And as it relates to disability-adjusted life years, it was also 10th leading contributor worldwide and is increasing according to the WHO. The question I want you to think about is, although these numbers are alarming, are they accurate? And I'll come back to this throughout the presentation. So we thought initially about the role of emergency medicine in addressing some of these things that were evident and problematic for the guys in Ghana. So we formed a partnership with Kwame Nkrumah University, the Ministry of Health, essentially everyone in Ghana who was related to working with acute and emergency care. We got some pilot funding from the NIH, from the Medical Education Partnership Initiative, which was written by our own Dr. Cunningham, and Professor Donko in Ghana was the PI there. We had matching funds from our own department here, one-to-one, for the 5-year period of this pilot grant. And the grant was meant to create training programs for physicians, nurses, and exposure programs for EM medical students as well as the EMTs in country. So we started out by trying to figure out what the population in Kumasi looked like, what the emergency department population was going to look like. So a couple of the first projects that we ran in the associated papers here, we did a needs assessment for the emergency nurses because we had a nursing training program as well. We looked at the pediatric population that were presenting to the emergency department for treatment there. We also looked at folks that were actually bypassing healthcare facilities that were closer to where they were injured or had their acute problem and then came to us in Kumasi at the referral center. We then did an assessment of the EMS services that were available in the region of the country that we were working in, and then lastly described the characteristics of the adult population that was presenting to the emergency department for evaluation. We used most of this data to then inform the training program. So the nursing assessment one led to the development of a nursing training program that was more clinically relevant to what they were seeing. Same with our residency. In that time and through the process over the last 8 years, we've had more than 20 resident-led papers by our residents in Ghana with more than 20 international presentations of that same work that they have done. For me personally, after the initial clinical training aspect, the next step for me was to learn basically the language of clinical research. If you've known me for more than 2 minutes, you know that I was not born a clinical researcher. But the process was that we were trying to do this thing in Ghana where we were trying to create a sustainable system in a way that had never been done before. And I had to decide and find a way to describe it and understand it in such a way that then it could hopefully be reproduced in other parts of the country and then hopefully beyond that. So I did a Fogarty Fogarty Global Health Research Fellowship project, which was funded by the NIH for a year, and I was mentored by our own Dr. Mayo, Dr. Barsan, Cheryl Moyer over at Global Reach, as well as Charlie Mock, who's over at the University of Washington. And what we did with that research project was we tried to do a preventable death review using a multidisciplinary panel under a structured implicit review process to look at the preventability of death and the appropriateness of care that people received when they arrived to the hospital secondary to a traumatic mechanism and then had death as their outcome. As we were doing this, we realized that we had insufficient accurate data to even make any sort of real assessment of the preventability of death. Our initial plan was to look at 50 records for every year since 2012 and see over time if there was a difference in the types of errors that were being made as emergency medicine became more established in the hospital system. Well, they have roughly 300 deaths a year related to trauma, and from 2010 to 2015, we were only able to find 45 total records. The records there are paper. They are stored, and Dr. Carter can tell you, they're stored in this huge shipping container, and then it gets wet, and then stuff disappears. Of the 45 records we found, 5 of them were patients when we reviewed the chart that actually did not die. The documentation of care is just as good as the ability to find the chart itself. Another problem we ran into was the fact that autopsies, which is often what you use to sort of add to your clinical documentation and to the imaging, was often never done. And if it was done, there was no way to actually trace that patient from the emergency department care or the outpatient care to the inpatient care to the pathologist. They had different numbers, patient identification numbers. So again, the point I made before was, although those numbers you see, the 1.24 million is alarming, is it really accurate? So in our findings from the preventable death study, what we found was that about 35% of the deaths that occurred, as it was reviewed by the neurosurgeons, the trauma surgeons, the emergency physicians, the anesthesiologists, were possibly preventable, either possibly or definitely preventable. The more important part of the study was looking at the areas where suboptimal care occurred for the patients, including airway management and documentation of care. So that graph there just shows you the percentage of the patients that we reviewed that had issues with their airway management that we considered suboptimal. So after finding all these questions, the next step was, how do we sort of get better data so that we can actually start to better understand what we're seeing in the department there? So I was able to get supplemental funds and built a clinical research database, which is electronic at the hospital. We modeled it after the American College of Surgeons Trauma Registry, but then added things that were locally specific. And it contains information on pre-hospital care based on the EMS system or the individual transport. We have referral forms from the initial hospitals that are part of the database. They have processes in there from the ED care, including procedures, timing of imaging. We've got outcomes measures beyond death and admission, and recently added injury severity scoring data software to the database. We adapted some of the questions from the American College of Surgeons to make sure that it fit Ghana. One of the things that we don't have here are non-factory manufactured seats in the car. In Ghana, they will buy a Benz, which is sort of a multi-person, 12-person vehicle, take out the seats that Mercedes brought, and then put in new seats that now seats about 36 people. And then those cars run into each other, and then we get new injury patterns. It's all kind of fun. Our database there now contains over 10,000 patients of all ages. The initial answers that we were finding have led us to submit 2 R21 grants, which are currently under review, looking at the traumatic brain injury that's occurring in the region, and then looking at the post-acute management of injuries in Ghana. We've partnered with our colleagues in biomedical engineering to try to look at some low-cost, high-fidelity models that we can use to help with recovery after the patients have been acutely injured. So right now, for next steps in our program, we're establishing 3 more emergency departments. We've trained now 30 attendings. We've got over 200 nurses that have been trained in our program. Of the 30 attendings, we are now dispersing them in a specific pattern to the teaching hospitals in Ghana, of which there are 4. And in the next 2 to 3 years, we should have functional emergency departments in each of those teaching hospitals, as well as training programs. We are now adding the Road Commission, which has information on all the accidents that occur by the roadside that are reported to the police, to our database so that we can start to create a network and create a surveillance system in the country. Our program graduates have now become visiting faculty for a new EM residency in Addis Ababa, Ethiopia. They are now providing expertise, just as Michigan did when we first started the program in Ghana. The database is now being expanded towards an electronic medical record. We've been able to gather successfully accurate data in such a way that we are now looking to take it to the next step and create an EMR that would then capture information on every patient there, and then have specific databases to look at some of the areas of most significance to us. We have a significant number of critically injured patients and acutely ill patients that we don't really understand well, so creating a critical care database is going to be super important. And then all the cardiovascular emergencies that we're seeing there right now, again, have had little investigation. So providing accurate data essentially is what we want to get, so we can provide the policy recommendations and think about the implementations of inaccurate data towards providing care in these developing environments. One of the things I realized was that a lot of money, a lot of funding gets decided based on how much or the prevalence of certain things in the country. Yet we have no real accurate way of measuring prevalence in these countries. We sort of estimate. how much trauma is happening, how much cardiovascular disease there is. So I think for us, creating accurate systems of measurement will be one step towards actually providing data towards the policymakers and some of these funders to actually fund some of the things that we believe to be significant. So just a couple of words of thanks. Our initial project started with Dr. Cunningham, Dr. Barsan, Dr. Carter, and Dr. Walker, and then we've all sort of moved on and progressed through our clinical careers. I wanted to thank my mentorship team. One of the important parts of developing as a researcher is having appropriate mentors, and as you see from my list here, my mentors are all over the place and mentor me in many different ways to sort of help me process all the different things that we are trying to do. I want to thank the department leadership for all their support and allowing me to continue to travel as frequently as I do. I have to thank my wife for allowing me to travel as much as I do too. And when you see her in the department, please don't mention that I'm not here. Okay. I want to thank the guys at Hurley for always, again, allowing me to not be seeing patients clinically and be traveling all over the globe to move this important work forward. Last but not least, my folks in Ghana who are truly partners. When we set out, the goal was to create partners, not to create people who are going to be forever dependent on us, and I think we are well on our way to doing that. Of course, I got to thank my admins who make sure that my life is scheduled in a way that is actually feasible. So, thank you.
So wait, don't run away yet. I just want to ask one thing and then I can open up for questions. So understanding we asked you to talk about research. I just wondered if you could just spend like one paragraph and kind of give an update that the medical education work and the success of the residency there has been amazing. And I just wonder if you could just update the room a little bit about that work and where that is now.
Yeah, thank you for that question. So the human capacity for health work that we're doing is sort of hidden. As I've learned over time, nobody really wants to fund capacity building. We sort of want to fund projects and distinct research projects, which is not a bad idea. But the work we've done in creating a clinical residency through a department that's functional has now sort of blossomed to the point where we're working with the ministry in Ghana to create regional emergency departments throughout the 10 regions in Ghana. If you look at the work that's been done in global health, and it's not a boastful thing to say, nobody else has really been able to do that. We've invested so much time on the ground providing them bedside clinical education, and I think it's worked well. We now have the only residency in Ghana that's driven by attendings. Most residencies, I don't know if most people are aware, most residencies in developing countries are resident run, meaning the resident does surgery by themselves. Their attending is off somewhere working likely in a private institution to supplement their government salary. So the residents are slower to learn as opposed to a setting where your attending is there with you all the time. Obviously, you can see the implications for patient care and patient safety and all the broader sort of complications that come with it. But with the success of the model, we were approached to help in Ethiopia. And I mentioned it to my wife, and I almost had to run out the house. But the beauty of investing in the way we have in our people on the ground is that now I don't have to spend 8 months on the ground in Ethiopia. I've got 30 attendings who are available, who now can go to their Ethiopian partners and act as the faculty and help them create a system that's well run and clinically focused, with the piece of gathering, again, accurate information so that we can model and change and modify their training programs to suit what they're actually seeing in their countries.
Yeah, thanks, Rocky. The medical education component and the success of that model for West Africa and for all of Africa just really is amazing and can't be oversold at all. Other questions for Dr. Oteng? In the back. I would suggest shouting.
Yeah. Good afternoon, Dr. Oteng.
Good afternoon, Yemi. How are you?
I'm well, thank you. How are you?
Good.
In all seriousness, thank you for this presentation. As I was telling one of the other residents, one of the reasons that I was very fortunate to match here is because of the mindset of the work. I was I was kind of wondering if you could just kind of speak to the role of the community worker, which has been kind of something in terms of resource challenge areas, especially all over Africa, and kind of how it integrates into the model, because this is a training program, but I'm sure there are multiple levels.
Right, that's a great question, and his question was about how we integrate the sort of lower level staff and available resources in the country into what we're doing. So oftentimes it looks like a top-down approach where we're training these super skilled emergency physicians in a vacuum, but that's not really the case. We have partners all throughout the country, Ministry of Education, Ministry of Health, people that typically don't even speak to each other. We got them to talk to each other and through me. I would go and spend time in each of their offices and explain to them what part of the program was pertinent to them. So the Ministry of Education is worried about, okay, we need to train more doctors. The Ministry of Health is worried about, I need doctors all throughout the country so that every person has access to a doctor. So we have integrated all that we're doing with them in the sense that they own it, right? Our residency there is run without any money coming from the US, and it's gonna be that way because it was built that way. I think what happens in global work is that we assume that they can't do things. A lot of work is focused on training the nurses to be better nurses and super nurses, and I think that's not really necessarily the best idea, right? I think if we build expectations but work with what they have, like creating PAs in the country, right? That was something that people were working on creating, medical assistants, because the villagers could do with the medical assistant. I'm like, well, what's the difference between the guy who lives in the village and the guy who lives in the city? It's just location. Right? If we build a system where we are training folks, emergency physicians, emergency nurses, physician assistants, who come from that area, they have no problem going back, right? They didn't grow up in the city. They don't love the city. They don't need to live in the city. Some of the issue with getting care to where the population is that you're not training anybody from that population. So in our selection process for the residency as well as for the nursing training program, we look at where they're coming from, where they grew up, and actually select preferentially people from areas that are underserved so that we train them. And when they come, they have a nice long discussion with me, which I'm sure they thoroughly enjoy, about the fact that once they're done, they don't really have a choice, right? They're gonna go somewhere in the country where we can use them to sort of build more capacity. So that's how we've addressed that.
For those residents out there, wait till Rocky sits down with you and tells you where you're going right after you finish your training. That's coming next. Other questions? Great.
All right, thank you.
Thanks so much.